like it. They'll probably already be seated like this in this position because this is typically how we are in an exam room. So also in honing your clinical skills and honing your subjective and your objective and getting your flow together, also try to keep in mind of how to consolidate things when patients are in a certain position. So what I mean by that is don't necessarily have to go in order on the way that the systems are outlined in your text or the way that we've been presenting them through Shadow Health or this, that, and the other. You can take care of whatever you need to take care of at whatever level or position you have the patient in. We don't want to turn this into a workout. We don't want to do a lot of up, down, get down, walk, come back, get back up, right? You want to try to consolidate as many things as possible.
I do that to people all the time.
So, so anyway, so for GI, our position for this assessment is what? Supine, laying down, okay? You may see wherever you're doing clinicals at, someone auscultating bowel sounds and doing a bowel exam. They'll listen in this position and then they'll mash around. That is totally wrong. They're taking shortcuts and taking the easy way out, and they're not a good preceptor. Because you cannot do a GI examination in that manner. What's our order of exam for GI?
Inspect,
Mhm.
auscultate,
Okay.
percuss,
Great, all right, perfect. So, this is nothing new, it's just stuff we've been doing all right, okay? There's only a few special provocative tests that we'll throw in and that's it. So one thing to do, which is technically not on the abdomen itself, but is tied in, especially if someone comes in with flank pain, or burning upon urination, or peeing blood, what do you want to assess for in this position? CVA tenderness, okay? So that is, you take one hand and you make a fist, you place it over the kidney. So position is important. We don't want to see people up here on a scapula saying that they're assessing for CVA tenderness, nor do we want to see down here below the waistline, okay? So we're trying to send a wave of energy through the posterior thorax to the kidney and see what that elicits. So we place one fist over and then we hit with the other, okay? We aren't trying to beat the patient up. I mean, it's force, but it's not like stupid, okay? And prep them, again, we tell them, hey, you're here today complaining of blah, 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 blah. You're gonna feel me kind of tap over your kidneys here for a minute. I just wanna get an idea of what's merely a little uncomfortable or painful versus what makes you wanna kick me in the face or something like that, right? But don't just walk up to me and go, pop, pop, okay? They're gonna jump and you're gonna think it's a positive sign when all you did was just scare them, okay? That's not a provocative finding. So, boom, boom, right? Look at them while you're doing it too, right? See what their facial expression is, okay? And that's just assessing for CVA tenderness, okay? We don't separate, for purposes of this course, GI versus GU and renal, but that is assessing for presence or absence of CVA tenderness, okay? So that can be done in this position. So you can also do that, by the way. So if you have someone who comes in with a complaint of cough congestion and nausea, vomiting, and flank pain, you can do all of your ENT and cardiac and respiratory assessment, and then do that, and then maybe lay them down for the GI instead of look in their ears, lay them down, check out their belly, lay them back up, listen to their lungs, listen to their heart. You know what I'm saying? That's what I mean by trying to consolidate stuff. So whatever position you can take care of stuff in is, we're going to try to minimize all the up down stuff. So then we'll ask the patient to lay back in a supine position. They're going to have to scoot back because we don't have foot extenders So you don't want, also make sure if you're in clinic setting, if someone lays back, you pull the footrest out underneath them because it's very uncomfortable just to have feet laying and dangling. So even though I said we aren't having folks disrobe or this, that, and the other, you can ask your patient if you want to inspect, hey, do you mind me lifting up your shirt? If they say, yeah, I'm really not comfortable with that, then you say, okay, I would, normally I would have them lift up and I would inspect, but we're gonna bypass that for, whatever reason, okay? If they do it, great. If they don't force the issue is all I'm saying, right? Okay. So also, like I talked about, patients are stupid, okay? They don't understand terminology like we do. So this would also be a good time, especially say maybe if you forgot to ask them about past surgical history or you forgot to present it in a way that they understand. You can easily, by inspecting, if they allow you to lift the shirt up, you're looking obviously for any distension, but you're also looking at the surface of the abdomen for any scars that may cue you in to, if you see a bunch of little laparoscopic things in the right upper quadrant, well, it looks like something's been done here. I might want to, hey, did you have to have your gallbladder removed? Did I ask you about that? No, or do you remember that? Oh yeah, now I remember. I forgot to say that earlier, something like that, right? That'll kind of save you some time, right? So you're looking for any evidence of any previous procedures or surgeries, right? So we'll inspect again if the patient allows us. If not, we're just going to move on. Then we do what? Auscultate. What's our order of auscultation? There we go. Okay. We aren't going, we're going side to side, right? We aren't going up, down, okay? So, just like we talked about, left upper, right upper, we'll work our way around, okay? What else can I do in this position? Say we're here with some sort of cardiac complaint.
Heart sound, abdominal aorta.
Can, but yeah, so I can listen for bruits over the abdominal aorta. I can also check for femoral bruits, right, in this position, okay? So again, that's what I mean by going and trying to consolidate all that you can. So we go through, we auscultate. How are we grading our bowel sounds? Right, we aren't just saying bowel sounds are present in all four quadrants, okay? It's hypoactive, normoactive, one of the few times you can actually use a word that sounds like normal, or hyperactive, okay? How long should you listen for? If you don't initially hear bowel sounds when you lay your stethoscope on the abdomen.
Up to 5 minutes?
Give it, 5 minutes is excessive.
1 minute.
Give it up to a minute, okay? And then the other thing that we'll see is people get out of order, and if we go and if we mash on the belly and then we come back to listen to it, we've created artificial sounds by going around and mashing. So that's why it's important with your GI assessment to go in order, because we want to get an accurate representation of what's truly going on, not something that we contributed to or we created, right? So inspect, we'll auscultate, okay? Then we'll come through and I'll usually start with light palpation. A lot of times I will use, especially with kids and some dramatic adults, prep my patient first, because a lot of times if there's a lot of little drama from mama going on or something like that, we can, you can say, okay, I'm gonna mash on your belly here for a second. Tell me this is painful. Oh God, oh that's killing me. Oh, that's killing me, right? So I will tell them while I'm listening to their abdomen. A lot of times when I listen, I'll say here, I'll sit here and I'll say, hey, just listen to your belly for a second, and I will apply some force downwards with my stethoscope, and I'll look at their reaction. And if they're just sitting there staring at the ceiling going doop, 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 okay, I know, okay, we're okay there. So then when I tell them, okay, now I'm going to touch on your belly here for a few minutes, and I come here and I lightly press down with a fraction of the force that I used when I was listening, and they come flying off the table going, oh God, you're killing me. I'm like, BS, right? That's a bunch of crap, right? So that's a nice little way to try to really get an accurate representation of what's going on. So when we are going, so I'll go through and I'll lightly touch, and I'm looking at their face to look at the reaction. I'm not staring down here at their feet. I'm up here, okay, my gaze is up here. And I go through my 4, and then I go back with a little more firm pressure, okay? I'm seeing if anything changes in terms of any sort of reaction or if we elicit anything. What are the things that we're looking for in terms of when we're pressing on the abdomen that we're noting for presence or absence of?
Appendicitis.
Those are diagnoses.
Tenderness, masses.
Tenderness, masses, rebound, guarding, right? Do we know the difference between those? Okay.
Rebound.
Pain is worse after you depress, right? Okay, that's rebound. Guarding is if you go to press that area and they're already, right? Or they're trying to cinch up or something like that, okay? So you're noting that as well. Is there any rebound, guarding, or tenderness? And then you note what location: left upper quadrant, right upper quadrant, left lower, right lower, so on and so forth. Mid-epigastric. Okay. We know the quadrants of the abdomen, right? That I just rattled off. Okay. So make sure that you're squared away on that. This is not the belly button anymore. This is what? Thank you. All right. Great. Perfect. Okay. So provocative testing for the abdomen. There's just a handful of things that you guys are going to be held responsible for. First one that we'll demonstrate is in the right upper quadrant. We have 3 organs that share a similar pad of real estate in the right upper quadrant. We've got liver, gallbladder, pancreas, okay? So when someone comes in, they're complaining of right upper quadrant discomfort, that should start to kind of give you a working idea of what you're dealing with. Sometimes you can get referred pain from the other side of the abdomen, but typically right upper quadrant is going to be one of those 3 things. If they've already had a cholecystectomy, well, that narrows down the list, right? So, typically liver's not going to cause pain unless we're dealing with end-stage liver disease, in which case we should see a lot of other systemic signs, systemic jaundice, and a bunch of other stuff. No one's going to have that. So more commonly, it's going to be something related to the gallbladder or the common bile duct that connects the gallbladder to the pancreas. So with clinical signs of whether we're dealing with cholelithiasis or cholecystitis, is typically right upper quadrant abdominal pain, right? Pain's usually worse after eating a large or fatty meal. A lot of times they'll have pain that radiates to the right upper portion of the back, but there's no underlying musculoskeletal etiology. Or they'll have a discomfort, a vague pain in the right shoulder without any underlying musculoskeletal etiology. So usually increased flatulence. There's another sign in terms of belching or breaking wind. Usually occurs more in females, more in population that's fair-skinned, and more in females that are still of reproductive age that are fertiles. We have the 5 F's of gallbladder disease: female, fair skin, fertile, flatulence, and fried fatty foods. Okay? Yes?
I had all those symptoms and I swear to God it was my gallbladder, and I was in a shift in the middle of the night and rolling around my office, like in pain anyway. As soon as the ER tech came and got me, because I called the supervisor, I'm like, I can't work. They rolled me in, it was a kidney stone, but I had all those symptoms.
Wow.
So, yeah, that would have, CVA tenderness would.
Always heard that as female, fair, fat, and 40, but you're saying
There's that, fertile.
female fertile what?
Female, fertile, fair skin, flatulence, and fried fatty food.
Okay.
So,
Yeah, I was saying the same thing.
all right.
That's what the 5 is.
So, and sometimes you can still, by the way, have people who have had a cholecystectomy, and they may come in with some of these signs, and you're like, but your gallbladder's been taken out. So if they especially had gallstones, so typically when the gallbladder gets sick, gallbladder is the only other organ in the body besides the heart that acts as a pump. Okay, you can actually measure an ejection fraction on the gallbladder just like you can on the heart with something called a CCK hydroscan. Not a regular ultrasound will show it. You're wanting to measure how well the gallbladder is pumping. So people who've had their gallbladder taken out, so it can fill up with either fluid, sludge, bile, or it can fill up with stones, gallstones. It's like a sack of marbles. Once that sack gets filled, the marbles start spilling out of the top. So when you get a gallbladder that has a ton of gallstones in there, and that sac gets filled, then those stones can fall over into the common bile duct, which connects the gallbladder to the pancreas. So some people who have had gallstones and have a gallbladder yanked, sometimes there can be a little stone that falls out and falls into the common bile duct, and it's called a retained stone, and it can cause problems, usually shortly thereafter surgery, but sometimes it can be several months down the road. Or if you get someone who has a sick gallbladder and something gets into the common bile duct and starts to also piss off the pancreas, and you get a concurrent pancreatitis that goes along with it. So, but to assess or stimulate the gallbladder, we have a special provocative test that we use that's called Murphy's sign. Okay, we're assessing for the presence or absence of Murphy's sign. There's a few different ways to do it. I'll demonstrate two of them to you. So, one is I start up at the head of the bed. I'm going to come in from the top, and I'm going to find my costal margin. I'm going to come about 2 finger breadths inside of that, and you're going to kind of hook your fingers underneath the rib cage, and you're going to push down. What you instruct the patient to do is you tell them, all right, we're going to do a little test here to try to see if you got an angry gallbladder or not. On the count of 3, I'm going to have you take a big deep breath in. You're going to feel me kind of hook my fingers underneath your rib cage a little bit and push down. When I let go, I want you to exhale. I want you to blow everything out. Positive test is not them necessarily having pain. As they're taking that deep breath in, and then you start to mash down, if they suddenly stop inhaling and they go, that's a positive provocative sign. Okay? If they go all the way in and blow everything out, don't even flinch, we're fine. Okay? So count of 3, big deep breath in. When I let go, we're going to blow everything out. You got it? All right, here we go. 3, 2, 1. You really mash, by the way. I'm not going to do it on her. And then you let go. And you're looking again at their expressions. You aren't looking down here or looking at the MA or whatever like that. Okay? So that's one way that you can do it. Another way that you can do it is you can take an approach here from down at the foot of the bed without the deep breath in, and you'll use essentially these 2 fingers, same landmark, costal margin. You come about 2 finger breaths in there, and you're going to come in right there and really kind of mash the gallbladder up against the diaphragm a little bit and see what happens there. Okay, so that is Murphy's sign. Okay. Now, another thing that you should do as part of your GI examination, by the way, I should have done this when we were doing the other stuff first. That sits in the right upper quadrant. So we got liver, gallbladder, and pancreas. Okay. You always want to measure your liver span. Okay. That should be a component of every GI examination. You are looking and noting, is there a presence or absence of what? It would be a medical term for an enlarged liver. Hepatomegaly, that's right. Okay. So, there's a few different ways to be able to measure liver span. Now, I will say your metabolic syndrome patients, so people who have diabetes, hypertension, hyperlipidemia, over 70% of those have what we call non-alcoholic fatty liver disease. You'll see that as an incidental finding on ultrasound reports all the time. People with uncontrolled lipids are also prone to have it because fat particles that float in our bloodstream, they have an affinity for the surface of the liver. It is their club, it is their hangout, okay? So you have uncontrolled trigs and uncontrolled LDL and total cholesterol. Those fat particles will start to adhere to the surface of the liver. And over time, if it's untreated, it builds up and builds up, can start to interfere with liver function. And it can change the contour of the liver. Also, patients who are morbidly obese tend to have a larger span liver than our other folks. So there's a couple of different ways where you can assess liver span. A lot of it is going to be determined upon the quality of your stethoscope and the quality of your ears. So you can do what's called scratch test, where you will use your stethoscope. You start way down low. Don't start where you anticipate the liver to be. All right, you can get fooled. Okay, so you start very low and you work your way up to the bottom of the liver border. So what you do is you take your stethoscope, and as you scratch, when you're over hollow area or viscous area where there's just bowel, you're going to hear that sound transmitted very easily. It's going to be a very pronounced, hyper-resonant sound. When you get over an organ, that's going to turn dull, okay? So you will hear, and then when you get over the liver, you can hear that change a little bit, and then you note how many centimeters away you are. Now, there's two different landmarks you can go by. You can look at your text. I forget which one the bigly text goes. If it goes from the costal margin or the sternum or the midclavicular line. I forget what they use in your Bates text. But anyway,
Better than 9 centimeters.
you'll note that, and again, so that's one way. That's the scratch test, and now you can see why that's subjective based off of
Sternum 5 to
quality.
7
yeah,
So what are you hearing?
So you're hearing over hollow bowel. It's, like I said, a very hyper-resonant sound, okay? You can hear the noise easily transmitted, kind of like if you're doing your egophony and whatnot for lung sounds. So where there's air, noise transmits and goes through very easily. When you get over something that's solid, that noise is not nearly as pronounced. It's not very resonant anymore. So when I get over the organ and an organ, and here in the right upper quadrant, we know liver is going to come down. We know our anatomy, know where it's located at. That's where you hear that change, and then you can kind of note your distance, and then that's what you document, and whether it's an expected finding or if you think the patient has hepatomegaly. Okay, so I like stuff that doesn't have moving parts, meaning or different moving factors in an equation that I can't control. Okay, so I like to percuss. Okay, so just like where we demonstrated the other time in terms of percussing the lungs for areas of consolidation, same thing on the abdomen. Start again down low. Don't start where you think the liver's going to be. Okay, you want to start down low and work your way up. Some people surprise you. I have encountered sometimes before on patients where I'm starting here and I'm just barely above the waistline and I'm feeling the bottom lobe of their liver. It's like, ooh, hey, Houston, we got a problem. So I'll start right about here and okay, hear that? Very hollow, very hollow, very hollow. Hear that versus that, okay? That's where I know I'm coming into contact with something solid, okay? And then I'm able to measure and say, hey, I'm good here. I've got normal liver margins or margins that are within expected limits, or hepatomegaly, okay? You can also hook through deep palpation, either coming this way or that way. That's going to be, again, very difficult depending on a patient's body habitus and the amount of visceral or adipose tissue that they have on the abdomen. All right? So, I prefer percussion because we take a lot of extra factors out of the equation, but whichever route you want to go, fine. Text also, I think, talks about assessing spleen and splenomegaly. I can tell you that in my career, I've only ever been able to, even in someone with mono and they have an enlarged spleen and splenomegaly, I've only been able to feel the borders of the spleen twice. Okay, even on very thin statured folks, it's just very, very tough. Spleen sits where?
Left upper, underneath the rib.
So ideally you're kind of pushing back from up here and you really got to get deep in and down there, and it's just not even You have to know it, but that's extremely, extremely tough to do. But make sure that you assess liver margins in whatever manner you deem fit, okay? Make sure though that you start low. Don't start mid-abdomen or up here. You'll get fooled, okay? So, if you're staying on the right side, if someone comes in and they have lower abdominal pain, especially in the right quadrant, what are we thinking? Appendicitis. What if we're female? Some sort of ovarian pain, ruptured ovarian cyst, right? Several things. How does appendicitis usually start off? Anyone know? Usually pretty vague symptoms. Usually starts somewhere in the upper or mid-epigastric region. Nausea, maybe with or without vomiting early on, usually just mild nausea. Just not feeling it all that good. Some people come in talking about complaint, I ate something, or it's just kind of hanging out longer than it should. Later, as the appendix gets angrier, the pain will gradually then move and then shift and localize in the right lower quadrant. And we become sick. If we were just a little nauseous before, maybe we start puking a little bit. We maybe start becoming febrile. All of those are typically later in appendicitis. So, now we are doing our next provocative test in the abdomen, and we are assessing for tenderness over what landmark? McBurney's point. So we have Murphy's up here, so stuff is confusing a little bit in the abdomen. Murphy's, right upper quadrant, McBurney's, right lower. Appendix sits lower than what you think it does. Can't count the number of times I've had folks come here and say that they're assessing for McBurney's point. You have to get below the waistline. You have to get your fingers right here off of the bony landmarks of the hip and pelvis, and you're drawing essentially a line up to the left upper quadrant from here. This is your provocative point to assess for McBurney's. It's not here, it's not here, okay? It's here, all right? You push down, you let go. And again, you're looking for the same things we did on our general palpation of the belly: rebound, guarding, tenderness, okay? So another thing that you can do that is specific and sensitive to the appendix, and can also be a test to help you ascertain if you're dealing with pancreatitis as well. These are two organs in the body that you can stimulate by sending a shock wave through the peritoneum, okay? So you can do that one of two ways. It's called a heel jar test. So you can have the patient just laying like this. You lift the leg just a little bit here, and you smack the bottom of the heel, and you're sending a wave of energy up here that if they have an acute appy, that should be very uncomfortable, or if they have a pissed off pancreas, that'll also get their attention, okay? This is a little difficult to, you can do it again depending on body size and your ability to lift a leg and stuff like that is gonna come into play. Ideally, you do this with them standing, and you have them instruct them to stand up on their tiptoes, slam down really hard on their heels. It's not rocking, it's not this, it's tough, right? With kids, I'll have them actually, I'll tell them, hey, I wanna see you jump off the exam table for me, okay? It's also called Markle's test. But just layman's, you can refer to it as the heel jar test or Markle's. I remembered it by Meghan Markle, who's the Duchess. She's like this big of a round. If she were to jump up and down on her heels and do the heel jar test, she'd probably break in half because she's like teeny tiny. So that's just a little mnemonic. Mnemonics will get you everywhere in school. So do the heel jar test, and you're looking to see if when they do that, if they have an acute appendix, they're going to grab right here and go, ugh, and sometimes they even project a vomit their toenails across the room, which is always entertaining. Same thing if they have an acute pancreatitis, a lot of times then they're grabbing here and doing the same thing. All right? So if you suspect either one of those, then that's your ticket. Again, we talked about right upper quadrant, gallbladder or liver, gallbladder, pancreas. Pancreas is a little bit more midline, okay? Pancreatitis, patients are sick, okay? They severe abdominal pain, puking their toenails up. They'll get can get big fevers pretty quick. It's usually brought on by excessive alcohol use and uncontrolled excessive triglycerides. Are the two main things that will piss off the pancreas, or mechanically from something from the gallbladder clogging up the common bile duct, and then you get an angry appendix, or sorry, an angry pancreas. So we also hear if someone comes in with upper epigastric discomfort. For pancreatitis, we're asking about some of those causative factors. You can also have folks who have GERD, severe heartburn, or peptic ulcer disease, that can also come in with pain and discomfort up here. So you can do your provocative heel jar test or your Markle's test, try to ascertain if you're dealing with an appendix or not, a pancreas or not. If not, then you ask about different things in terms of reflux or signs and symptoms of peptic ulcer disease. Usually pain that worsens with food, right? Or certain spicy foods, alcohol, excessive caffeine. So, Murphy's, gallbladder, McBurney's, get lower than what you think for the appendix with some sort of shockwave test through the peritoneum, okay? Also, if someone does have a positive heel jar test and you don't think it's an appendicitis or pancreatitis, then you need to be concerned about some sort of peritonitis or an acute abdomen. That needs to go someplace else pretty quick. Left lower, what do we have over here? Organs? It's got bowel, right? So left lower is wonderful when people come in complaining of pain in the left lower quadrant, because there's really not a lot there that can cause problems, at least in terms of solid organs. We just have bowel. This is typically where we have diverticular disease, either diverticulosis or the acute stage of that, diverticulitis, okay? These are people who will come in with left lower quadrant discomfort, nausea with or without vomiting, sometimes loose stools. We used to think that there was a high correlation between foods that have seeds or nuts in them. So eating peanuts, popcorn, raspberries, stuff like that. There's still a little bit of a correlation with that, but it's more of you get these little pockets of diverticula that form in the small bowel. If they become extremely inflamed, they can form abscesses, and then that leads to acute diverticulitis. And those patients also get fairly sick. But that's really all you got to be worried about here, unless you talked about the kidney stone thing that you kind of talked about, because our stones start at the base of the kidney, and then gravity takes over. Gravity does pull stuff down through the ureters, okay? So you can get a stone that can get hung up anywhere from here down to here. Once we get down to the bladder, you're pretty much home free, probably gonna pass that. So sometimes people will come in and they'll have left lower quadrant pain, but they may be nauseous, but they aren't puking. You run through a dietary history, they aren't checking off any of the boxes in terms of that stuff. They don't have a known history of diverticular disease or anything. And then you assess for your CVA tenderness, and depending how far down in the ureter it's traveled, even if it's about halfway down, you'll still get a provocative positive test there, and you know that this is probably a stone that's on its way down. So really stones, diverticular disease, that's really about it. UFNPs, you too will have to know, you know, inflammatory bowel issues and bowel diseases, Crohn's disease, ulcerative colitis, so on and so forth. But for purposes of this course, if someone comes with left lower quadrant pain, rule out a kidney stone, and then all you got left outside of that is diverticular disease. Constipation's another thing too, right? If we get plugged up, we can get plugged up down low or up high, okay? So that's another thing. Constipation can cause pain depending where we are and to what degree, because where you get hardened stool, it back builds with air, okay? That causes a degree of abdominal distension and discomfort, and you can have pain associated with constipation. The pain's coming from the gas, okay? So you clean them out. If it's down low, something that's kind of down towards the rectal vault, you can get that out with your enemas and so on and so forth. If we're plugged up high on either side, which is much more common than just down low, then you need something that works from the top down. So they have to drink from the top down to try to clear that out. And you also want to make sure they load up with a bunch of gas X or simethicone, because you got to clear all that gas out too. That's what causes pain.
Clozaril.
So, do what?
Clozaril
Yeah.
can cause severe constipation.
So,
And
a
you have to-
bunch of medications, a bunch of stuff that you guys will prescribe on the psych side can slow down the bowels, okay? Medication-induced constipation, they've got a whole line of drugs out for that now, caused by opioids and from psych meds that can slow down the bowels and slow down the guts, okay? Most common cause of constipation is poor water
Fiber
intake,
and water.
okay? People who suffer from constipation need to be drinking at least 2 liters of water a day. Water's like engine oil for the guts. All right. So we have that. Left upper, we've got kidney over there. Spleen's not really going to cause pain unless it's trauma and you're dealing with a ruptured spleen or lacerated spleen. We're not dealing with that. We've got stomach, okay? So gastritis, gastroenteritis. There's no real provocative testing for that, truly at all, okay? So, that's the belly. Questions about any of that?
So like, what would you like say as you're doing that? Like the bowel sounds, normoactive, hyperactive, no tenderness, no rebound.
Inspected the abdomen. I don't appreciate any previous surgical scars or masses. The abdomen is flat and non-distended. I have normoactive bowel sounds in all 4 quadrants. There is no rebound, guarding, or tenderness in any quadrant. Bless you.
Thank you.
There is no CVA tenderness. Any provocative testing that you would have done. That's probably pretty much it.
Okay, and then the liver margins.
Oh yeah, liver margin, yeah. No hepatomegaly. Liver margin is 2.5 centimeters behind, under the costal margin on the right.
So what are the normal margins again?
I ain't gonna give you everything. Read your text. Depends where you're going from, what landmark you're going from. Again, you got a few different options. All right, you guys will have to know that. So, yeah, so that's probably pretty much it on the belly. We aren't getting into pelvic stuff, like I said, for purposes of this course. You have a section on it that you'll be tested over, but for your practicum, right, we're not, that's no fly zone. Okay? Any other questions on the belly? No? Okay, all right. So we'll go with musculoskeletal. Here's where the train comes off the rails. All right. So we'll start with easy stuff first. We will start with the spine. We'll start up top with the neck. So someone comes in with neck pain. So with anything musculoskeletal, we're assessing for, is this acute or chronic? Okay. Is this an acute exacerbation of a chronic issue? Sure. And if it is acute, is it traumatic or atraumatic? Okay. Was there some sort of trauma, injury, or fall that precipitated this? Or, like I said, is an acute exacerbation of a chronic issue? Do they have known cervical stenosis or cervical degenerative disc disease, and they woke up that morning and their neck is just all locked up and angry at them or something like that, all right? So that's for anything musculoskeletal. So for the neck, we are dealing with the top of our spine, right? So we're dealing with right behind the occipital skull, going down to our tailbone. That's where our spinal cord sits, okay? So key things that we're assessing for neck, we go through and we do some range of motion, which I'll demonstrate here in a minute. And then with anything with the spine, we're always asking and assessing for any signs and symptoms of radicular pain or radiculopathy. Anybody know what I'm talking about with that? What a patient would describe that as? Sure, where? Upper extremities, okay? Cervical spine ties to this, okay? Ties to our arms. So they'll be talking about, I've got this pain in my neck and I've got this numbness or tingling or burning or ants crawling or it feels like my arm's asleep. Something like I'm about to shoot lightning bolts at the tips of my fingers, like a Harry Potter movie or something like that. I don't know. So I'll describe that. Those of you on the family side will have to learn all of the affected dermatomes that are associated with the cervical spine. Because if a patient tells you, because you ask them if they have that going on, you want to ask them how far down does that go? Does that stay, just come down to the elbow? Does it come all the way down into your upper arm? Does it go to your wrist? Does it go all the way to your hand or your fingers? Okay. If they say, I've got this pain and it comes down, it stops at about my wrist, then I automatically know that we probably have an issue with C4 through C5. Okay. Then you're also assessing, you'll want to assess for grip strength, okay? And you'll want to do a component of a neuro exam. If they are complaining of radiculopathy, you have to check your deep tendon reflexes in the upper extremities, okay? And then you ask them, they can have, is it unilateral radiculopathy or is it bilateral, okay? So anything radicular, so with the lumbar spine, the radiculopathy is in the legs, okay? Anything that's radicular needs to make you think that we have a disc issue going on, okay? A disc or discs have been displaced and they are pushing on something. On the back of our spine, all the way from the back of our neck down to our butt, we've got exiting nerve roots on either side. They look like ferns on a fir tree or Christmas tree. Come out like that. When discs get compressed, either acutely through a mechanical injury, or trauma or fall, or age, just years spent on the planet, right? We know in our spine we've got our vertebrae that are stacked on top of each other like blocks. In between there are our discs, which are made of a gelatin-like material, okay? So either acutely through an injury, those will collapse and squish a disc, or just through age, right? Gravity does what gravity does, pulls stuff down, joint space decreases, and we start getting squished. So discs, because they're like a jelly material, when they start getting squeezed, they can either squirt out to the left or the right, or both. That's when they come in contact with those exiting nerve roots that I was talking about. That's what lights people up, right? They can also get squished backwards, okay? And then they start encroaching on the spinal cord, okay? There's a big difference between cord compression versus cord compromise. I've had cord compromise myself, it's not a good time. So, that's what we're assessing for with radiculopathy, is where we know we got an issue with disc or discs, and depending how far down it goes, coupled with our provocative testing, we're able to pretty much identify, okay, I've got an issue with right C4 through C5, or I've got an issue with right C4 through C6, and on the left I've got an issue with C3 all the way down to C7, okay? So what we start off doing with the neck is you can either do this patient seated or standing, it's up to you. Come back. That's fine. You're fine. So first thing that we do is we palpate for any point tenderness. So I'll take my fingers and I'm just coming down and feeling each vertebral process all the way down the neck, looking for any point tenderness. And then I note what level that occurred at, okay? Then I'm also going to palpate the paraspinous processes, the surrounding musculature, okay? So with our neck, start up here, this is your levator scapulae that come down into your traps, okay? So someone who says they woke up with a crick in their neck, or had a whiplash type kind of injury, rear-ended, or fell, or something like that. A lot of times that will cause some of these paraspinous muscles to lock up. This can also happen with mundane day-to-day activities, especially in someone who has an underlying spinal stenosis or degenerative disc disease. I've seen people who just bend over to spit their toothpaste out in the sink, and they come up in a wrong manner, a wrong fashion, and they come hobbling in like this. Our bodies are smart in some areas, and they're very stupid in others. The spine happens to be one of them. Our surrounding musculature in our spine doesn't really do a good job of differentiating whether you just spit your toothpaste out in the sink, came up in the wrong way, or you just got rear-ended by a semi going down the freeway. Their instinct is they're like ants or bees when the hive's attacked. Their instinct is to surround and protect the queen, right? Same thing, our muscles, they can't differentiate between what just happened. There's like, oh crap, something happened, protect the spine. They'll lock up like that, okay? And so you'll have patients who may come in, they don't have any radicular symptoms, they don't have any point tenderness over any of the vertebral bodies, but they are just all locked up, and you can sometimes even find and palpate and feel where that area is just kind of locked up on them. So using pads of my 2 fingers, I run down and feel down the back of the levator scapulae and into the tops of the traps, and note, is there an area of point tenderness or contraction or something like that, okay? So then we'll run through some range of motion. Anybody know what planes we have for range of motion for the spine?
There's like the flexion.
Yep, so flexion, extension, lateral rotation, all right? That's what we got, okay? So I will put, especially if they had any point tenderness in any of these paraspinal areas, I'll kind of put my fingers over those areas and I'll run them through. I'll instruct them, hey, slowly put your chin down to your chest. Great, now come back up and look straight ahead. Head back at the ceiling. Great, now back straight ahead. Looking over this shoulder, backing car out of the driveway. Looking over this shoulder, backing car out of the driveway. Great. If, say, she had an issue with a neck spasm on the left, which range of motion would elicit the most positive response and cause this to tighten up and contract and cause pain? Rotation to the opposite side, okay? All right, so I'll run through all that, okay? Then we're gonna do our provocative test where we're going to, it's called axial loading or Sperling's test, okay? We're going to compress the vertebrae in the neck, and we're gonna see if that lights us up, especially if we're complaining of any radiculopathy, okay? So you start off neutral position. This is where, depending on the size of your patient, you won't do this either sitting or standing. It's up to you. Tell them, I'm gonna put my hands on top of your head, I'm gonna cup the top of your head, I'm gonna mash down on top of your head, I'm gonna let go. I want you to tell me if you feel any burning, tingling, shooting, numbness going down either arm and how far down it goes, right? So hands like that, and you mash straight down with some force, okay? And then you let go, okay? If they say, I felt shooting crap going all the way down my right side, then we can isolate each side. You have them tilt their head about 30 degrees to that side, repeat it, see what happens, do the opposite side, boom. Okay? And we're done. All right? That's neck. Flexion, extension, lateral rotation, and then axial loading, compression, Sperling's test, okay, for radiculopathy. And then noting how far down the radiculopathy comes. You don't have to know your dermatomes for your checkoff, but you need to say, they said it came all the way down to their elbow or all the way to their fingers or whatever, okay? All right.
So would you say that test, the axial loading, would you say that it's positive?
Yes.
Okay, and then how would
It's
you describe
positive,
the second?
positive not for pain, it's positive for radiculopathy. Pain does not make that a positive test. Radicular symptoms, shooting pains, numbness, tingling, going down upper extremities or upper extremity. Okay? All right. So for our low back, 2 positions. There's really nothing for the thoracic spine or nothing that we're holding you guys accountable for the thoracic spine. Thoracic spine really doesn't move. It's a stabilizing force between the cervical and the lumbar. Okay? So for low back, there's 2 ways you have to examine that. One is standing, the other is laying. Our provocative test for radiculopathy is called the straight leg raise. We're going to do that when we're laying. So, again, when you come in to your patient room, they'll likely already be seated up on the exam table. So, at some point, you have to get them down. You have to assess their gait if they're coming in complaining of low back pain. Again, we're asking the same questions. Is this acute or chronic? An acute exacerbation of a chronic disease. And then if it's acute, traumatic or atraumatic, right? Okay. So at some point, you want to watch them walk. So you just have them strut their stuff. And you're just assessing their gait, right? You're looking for, do we have a good lift off of the ground with our heel and our forefoot, okay? Or are we sliding a foot across the floor like Quasimodo? Okay, that's a red flag. That's foot drop. So, oh, sorry, on the cervical spine, deep tendon reflexes, you also have to assess deep tendon reflexes. With or without a reflex hammer, I use my knuckle and my middle finger, brachial, radial. Okay, 2+ and symmetric. All right, and then strength, have them squeeze your fingers, make sure that we're equal. Okay, all right. So the back, you want them to strut their stuff and walk, and you want to look at the gait. Okay. Then at some point, here, we'll face this way. We'll turn this way. We're going to do the same thing in terms of palpation, just like we did over the cervical spine. We're going to palpate the vertebra of the lumbar spine, and we're going to work our way down, noting any point tenderness and what level that occurred at. Okay. Typically for paraspinous musculature in the low back, that's mainly going to be right above the waistline. So I'll take my thumbs, come about 2 finger breadths off of the spine itself. And these are typically your erectors that'll kind of get angry and lock up with any sort of low back spasm or muscle thing. So same, here, face this way. I don't want you to hit your forehead on the exam table. So same range of motion that we did on the neck. We're going to do forward flexion. You want to know how far down are they able to get their hands? Are they limited just getting their fingertips to the tops of their thighs? They get down to their knees, their shins. Can they do a forward fold and are like a yoga instructor and they're just showing off? So you do forward flexion, looking at range of motion and how far fingers go. We come back up, we do extension, which is just leaning straight back like that, great. We do lateral rotation, 2 methods that you want to assess that. One is just side to side. They should be able to get their fingertips down to about the level of their knee. And then I also rotate a little bit. So I'll stabilize with my leg and hand here, and I will rotate this way and then do the same thing opposite direction, okay? So there's your flexion, extension, lateral rotation for the spine, okay? Now we want to assess for our provocative testing for radiculopathy. So again, lumbar spine, if we have a disc issue, that's gonna affect the leg. Just like we asked them, how far, are we experiencing any numbness, and if so, how far down does it travel, is what we're gonna ask them. Does it come down to the mid-thigh? Does it go to the knee? Does it go all the way down to the ankle? Does it go all the way into the foot and toes, okay? We're looking for signs of foot drop. We're also asking them for red flag issues with the spine that indicates a neurological and neurosurgical emergency. And that is something called cauda-equina syndrome. Anybody know what those signs and symptoms are? No. All right. So you ask them if they feel what we describe as or document as saddle anesthesia, meaning that they can't feel anything around their groin and their pelvis, like they've been riding a horse for way too long. Cauda-equina, that's where that comes from. Saddle anesthesia. So numbness in the pattern of a saddle, coupled with bowel or bladder incontinence. So asking them, have you peed or pooed yourself and not known it because you can't feel it? Okay. If they say yes, that's a, hey Houston, we got a problem. That is, we don't just have cord compression, we have potential cord compromise. Okay. There's one diagnostic tool that you have at your disposal, so someone, especially in the days of Dr. Google, can go online and read all of this stuff, and they can come in and hobble like this and make you think they have foot drop and say that they've been peeing and pooing themselves and all this other stuff. So before you call a neurosurgeon and get them on the line with your emergency, there's one tool that you have at your disposal to be able to rule in or rule out true cauda-equina. Anybody want to take a shot at what that is? Rectal exam. One tool. If they have rectal tone, it's impossible to have cauda-equina no matter what they're trying to portray that they've read online. All right. So, we'll finish up our exam with them laying. So again, if you have someone with GI complaints and low back pain, again, we try to consolidate some of our stuff here. So you want legs straight, so we're going to do what's called the straight leg raise. It's also known as Lessegs sign. So you instruct the patient, you're going to tell them, again, we try to walk through what we're going to do. Hey, I'm going to start lifting your leg up, okay? You're going to feel some pulling and tugging in your low back. That's just engaging muscles. We don't care about that, okay? Pain, back tightness is not a positive provocative test. We're looking to see, as we raise the leg up in the air, we're trying to pinch off those vertebrae and those discs in the low back. So if we suspect that we have a disc issue and we have radiculopathy reported on the extremity, this should light them up as you get the leg up between 40 to 70 degrees, okay? So again, pulling, tugging, discomfort here, you get someone with tight hamstrings, they may not be able to get way up or whatever. That we don't care about. We're only looking for numbness, tingling, shooting pains, exacerbations of that. So you cup their heel, you stabilize, you start coming up, and you ask them if they start feeling the shooting pains. You note about what angle you're at. Some people you can get all the way up like, you know, freaking yoga instructor, or like I said, a rocket or something like that, right? Okay. So you also want to assess for strength, especially if they're talking about the radiculopathy coming all the way down into their foot. I will grab on to their big toe like this. I stabilize the heel and I ask them to press up and down like you're working a gas pedal, okay? They should be able to resist your tension and your pressure, okay? If they can't work that gas pedal, then that's also kind of a Houston, we got a problem type kind of thing, okay? So you do that for the affected side and the unaffected side, okay? We do the same thing on the other side. So if you have, say they're talking about their shooting pain is over on the right leg, and say when you come over and you raise the left leg, that they say, I don't feel any shooting pains in my left leg, but it made my right leg light up again like you were doing it before. That's called a positive crossover leg raise, or a positive cross leg test. Okay? So, raise the leg, note what angle, prep them, tell them what's going to happen so they don't start writhing. That's not a positive sign, right? Radiculopathy, and then flexion and dorsiflexion with resistance against the big toe, okay? Then you have them come up. The last thing to do, just like we assessed for deep tendon reflexes on the upper extremities, is you have them scoot to the edge of the bed where their legs can at least hang off of the edge of the bed. And again, either with your knuckle or with a reflex hammer, you find your landmark and you assess your DTRs. You also will do it back here on the Achilles. Patellar, Achilles. Okay? That's it. F&Ps, you'll have to learn 4 other provocative tests when you get into your tract. But for purposes of this course, that's it. Okay? So flexion extension, lateral rotation, gait, straight leg raise, crossover leg raise, flexion, dorsiflexion against resistance of the great toe, DTRs. Done. That takes care of the spine. Questions about that? No. Okay. So, we'll think what I want to throw at you next. Okay, we'll keep it fairly easy still. We'll deal with upper extremity stuff. Hands, wrist, elbows. Okay. So, with hands, we're looking at stuff that we can see, and that's what I'm talking about when I'm sitting on an exam stool and patients talking, I'm constantly scanning them head to toe, looking at anything that's exposed that I can see. So I'm looking for deformities in the fingers, okay? You'll have 2 different types. You have Heberden's nodules, and you have swan neck deformities, and you have Bouchard's nodes. Your book does a good job of documenting and talking about all those and let you know whether you're dealing with age-related, years spent on the planet, osteoarthritis versus an underlying inflammatory issue or autoimmune issue like RA. So these are things that we can kind of look at, okay? If they are talking about stiffness in the joints of their wrists and hands that are worse when they first roll out of bed in the morning and tend to loosen up and get a little bit better, there's no underlying trauma, then that needs to make you think about rheumatoid arthritis. It could also be age-related osteoarthritis if we have some little mom and pop who's 80 plus years old and just took time spent on the planet. But if we aren't geriatric age, and they talk about that, then that's something that kind of gets your ears up for rheumatoid arthritis. And then you ask about other things that can affect the immune system and autoimmune disorders, fatigue, any other joint pains, so on and so forth. So, we also will commonly outside of that have pain that is brought on by overuse, gaming, keyboarding, right? stuff that we do on a daily basis. There's a tendon sheath at the base of the wrist on the side of the radius here that runs from right about here to here. That can get inflamed with overuse activity involving the thumbs. This, gaming, so on and so forth. So this tendon sheath will become inflamed. Patients will come in talking about pain in their wrist, usually on the thumb side, okay? So there's a provocative test that we can do for that. This condition is called de Quervain's tenosynovitis. Sounds like a French pastry or dessert, okay? It's an overuse, repetitive motion, repetitive use thing, pisses off this tendon sheath. So our positive finding, a positive provocative test for this is called Finkelstein's sign. You have them take their thumb and angle it straight down like this, like they're trying to make the number 4. Wrap their fingers around their thumb and then point the wrist down at the ground. That will bring that tendon sheath into play, and if they talk about pain and discomfort right there, then that's a positive Finkelstein sign, and they have de Quervain's tenosynovitis. Okay? The other thing that we do for the wrist, depending on, I can't remember if your text puts this under musculoskeletal or neuro, I see it in both, is carpal tunnel. Okay? Also overuse, repetitive use, repetitive motion, typically keyboarding, crocheting, knitting, other stuff like that can sometimes cause it. So the carpal tunnel is about the width of a watch band, a little bit narrower than that. And this is irritation of the median nerve. It's easy to remember because it sits in the middle, okay, mid-median nerve, okay. If it's carpal tunnel, they should be talking about numbness, tingling, burning, okay, kind of like radiculopathy with the neck, but this is isolated. Instead of traveling all the way down, this is just isolated from the wrist forward, and carpal tunnel will affect these 3 digits, okay. If they're coming in talking about these 2, saying, I got carpal tunnel, no you don't, you have ulnar nerve entrapment, ulnar nerve impingement. Carpal tunnel is these 3, okay? So anybody have an idea of what our 2 provocative tests are for this? Phalanx and Tennels. You must be done in a specific order. So phalanx is you have them mash their wrists together in a reverse prayer formation, like this, okay? You're wanting to compress the carpal tunnel. So this is how we do it, reverse prayer, wrists together. Have to hold it for 60 seconds. For your practicums, in the essence of time, because we have a running clock, we're not going to make you hold for 60 seconds, okay? You need to put them into phalanx. You have them hold for 60 seconds, and then you tell them to place their palms up like they're holding up 2 plates. And then you come and you tap over that median nerve, okay? And if that lights up these 3, then that's positive carpal tunnel. Phalanx, right, reverse prayer, Tennels, tingling the median nerve, okay? So, that takes care of hands and wrist. Range of motion, by the way, sorry, range of motion. Essentially, if someone can do this, make circles with their hands and wrists, we're good, okay? We're running through everything there. But you need to know your planes, right? We've got flexion, extension, pronation, and supination, okay? That's what we have going on with hands and wrists. So if there's any issues with range of motion, we palpate bony surfaces, note for any point tenderness, where that's located at. Assess strength, assess grip strength, have them squeeze your hands, which is also a component of a neuro exam. And then have them do finger to thumb opposition, which also knocks out one of your cranial nerves on your neuro exam as well, okay? And then I have them make okay signs, especially if they have pain in isolated digits. Have them like make an okay sign, whatever the affected thing is, and they should be able to hold it tight and resist you trying to pull through it. That's really all I need to know for that. Elbow. Most common things that you run into is lateral and medial elbow pain. These are also overuse injuries, repetitive use, repetitive motion. So we have our stuff from here and here and here for the hand and wrist. For the elbow, it's torquing motions. So folks who are in construction or mechanics or stuff like that, a lot of repetitive torquing and whatnot will irritate these two tendon sheaths. We have one coming off the lateral epicondyle. Medical term is lateral epicondylitis, otherwise known as tennis elbow. Coming off the medial epicondyle, which is medial epicondylitis, otherwise known as golfer's elbow. Very little has to do with tennis or golf. People who don't necessarily play tennis or golf can have these. Again, these are overuse, repetitive use, repetitive motion. So you ask them about motions that make this angry. A lot of times I'll have them try to torque on a doorknob, the doorknob in the exam room, or ask them, are they struggling to get lids off jars or stuff like that, all right? So usually it is just point tenderness. There's a tendon sheath that runs about the same length as the one in the wrist, from like here to here, okay? That there'll be point tenderness coming off of there. They'll also typically have some increased pain if you compress that and you have them start doing some pronation, okay? You can also fully extend the arm and get them into a little bit of flexion if if you have them resist you, and ask them to pull back, pull their fingers up. A lot of times they will sometimes struggle with that, okay? That's pretty much it with the elbow. You can have people sometimes who come in and they have, looks like a big piece of fruit hanging off the bottom of their elbow. That's called olecranon bursitis, inflammation of the bursa sac coming off of the bottom of the olecranon. See that a lot of times in elderly folks or people who rest their arms on chair rails all the time. You guys are not going to be responsible for any of the tendons and ligaments in the elbow, the F and P's. When you guys get into your tracks, you will have to know that. But for purposes of this course, if someone comes in with elbow pain, it's going to be determining lateral or medial and doing some range of motion, and that's pretty much it. Okay? All right. Now we get to the shoulder. Shoulder's rough. All right. Shoulder is a ball and socket joint. In fact, here, let's do this. I missed my food window earlier. I got to eat like every 2 hours or my system runs low. We'll take a quick 5-minute break.